I'm Vincent Okungu. I hold a PhD in health economics and specializing in healthcare financing. The journey to universal health coverage in Kenya, with my experience in financing, it's not that clear yet. We can think of systems to reach those who are not yet covered. The about 80 or so % of Kenyans that do not have access to the services they need. We only have about 17% of the population that is covered through NHIF and other private arrangements. There is 3% that is privately covered, and they also have NHIF coverage. And then NHIF coverage is about 99%, the formal sector. So we're talking about a 1% or less. The latest modeling we did was found out that there is less than 1% of the informal sector that is covered through the NHIF. Now the question is, what financing systems would make it possible to reach the 83% of the population that is not covered? I would borrow experiences from countries such as Costa Rica, South Korea, and Thailand. Because when these countries started universal coverage reforms, they were at the stage of economic development, same as we are now. They were low middle income countries as we are. Now, the current financing reforms to finance universal health coverage in Kenya emphasizes a contributory system. Contributory system is where everybody, formal or informal employment, is expected to contribute a premium into a pool that is run by an institution such as the NHIF. There are two problems with that. One is that as currently constituted, the NHIF contributions are pro-rich. You get that the lowest income earner contributing to the NHIF from the formal sector is contributing 5% of their salary into the NHIF. The person earning $1 million shillings, for example, is contributing 0.1% into the NHIF. So as we are, the financing system needs to be reformed to be pro-poor. We are taxing the lower income groups to pay for higher income groups. There is no financing system that operates like that. Second thing is that the benefits in the NHIF also tend to be pro-rich, or are increasingly getting pro-rich, because they cover only the formal sector. Formal sector have predictable income. Generally, they are probably better off than the informal sector. So they get better services than the people in the informal sector. You can see the current addition to the benefit package of the NHIF, where people can get surgeries, and there are also linkages with institutions such as AK Global Health, which can contract hospitals out of the country to attend to patients from Kenya. And these patients who go outside the country for treatment and funded by NHIF, they're usually in the higher socioeconomic scale. So I find increasingly NHIF benefits and financing are pro-rich. And we need a financing system that is pro-poor. Now, how do we get there to get everybody to be able to access services, quality health services, wherever they need them? The government insists on a contributory system. Yes, it can work. It has worked in some countries I mentioned, like Costa Rica. But this was supported by, one, rapid economic growth rate, which means that more and more people are getting absorbed into the formal sector. Secondly, there were very strict laws that if you were working in the informal sector and you're employing anybody, these people have to have health insurance coverage. We don't have such laws. In other words, we need to, if we are to go the contributory way, where everybody pays a premium to the NHIF, then there has to be deliberate steps to force people to pay. What Costa Rica did is that if you don't have an NHIF card, then you meet the full cost of care. In other words, you pay the doctor on your own, you pay medicine, everything. But if you have a card, then you're subject to government subsidies. So it forced people to enroll, to pay for premium. We don't have such a case here in Kenya. So we need such systems in. That is, if we have to go the contributory way,